Welcome everybody to the cancer webinar, which will be led by our doctors here today and the Senior Health and Wellbeing Coach. We have Dr. Sangeeta Padhanisamy, Senior Health and Wellbeing Coach, Jiga here, and Dr. Jamin Bhatt. Sangeeta, over to you.
Thanks, Yasmina. I'm really excited to invite Dr. Jamin Bhatt. He is a consultant urologist at Queen Elizabeth University Hospital in Glasgow, and he's going to talk to us about bladder and prostate cancer. I just want to invite the group to sort of put the questions as they arise in the chat. I'll be monitoring it, and at the end of the talk, hopefully Dr. Bhatt will have enough time to answer them, or we could take it up with him even after the meeting. So welcome, Dr. Bhatt.
Thank you very much for inviting me today to come and speak to you. I'm just going to share my slides. Excellent. Can you see my slides okay now? Yeah.
Yes.
Brilliant. Thank you. So, yeah, no, it would be lovely to come and meet all of you in person, but obviously, sunny Glasgow is well, not so sunny today. Thanks to Bunmi, my good friend and co-clinical champion with Prostate Cancer UK, who's invited me to come and speak to you about two cancers that I treat on a daily basis. So I'm a consultant urological robotic surgeon in Glasgow and also lecturer at the University of Glasgow. Fight Bladder Cancer is a patient-formed charity for bladder cancer patients with a real wealth of resource, and they've very kindly invited me to become their medical advisor. So my story, my journey with bladder cancer actually started when I was a final year medical student. See if my slide will move. So my mother had blood in her urine and painless hematuria, maybe a bit of discomfort. And straight away, as medical students, you don't really get much of urology training. But yeah, it just didn't sound right. So got her investigated, timely investigations and treatment. And she's still going strong at the age of 84, having sort of fought bladder cancer, survived bladder cancer. And again, early diagnosis is key. So I'd like to dedicate this talk to her and also to my family. That's my son and wife. Last year, we raised funds for Fight Bladder Cancer and walked across 5 city hospitals in Glasgow. I was completely knackered by the end of it. So that's just a quick overview of what we will discuss today with bladder cancer. And if you have any questions towards the end, please feel free to ask. So the last bit, filters and cascades, actually should be replaced by getting better faster. I was obviously copying and pasting, and the filters and cascades project is actually more with the prostate cancer side, but the actual quality improvement project that I've led on is called Getting Better Faster. So as I'm sure most of you know, the bladder is a pelvic organ of storage. It stores our urine and at an appropriate time voids. The embryological origin obviously comes from 2 sources: the urachus, which is the dome of the bladder, which comes from the allantois and the umbilicus. And then you have the cloacal plate, which gives rise to the rest of the bladder. It's lined by a specialized epithelium called transitional cell epithelium, which is specialized in that it does not allow urine to get reabsorbed into the system, and therefore it's a watertight system that allows passage of urine all the way from the renal pelvis down through the ureters into the bladder and out through the urethra. All of that is a transitional cell epithelium. There's obviously smooth muscle within the bladder called the detrusor, which has an inner and an outer layer. The bladder is covered by fat in most parts, and then obviously there are parts of it which is covered by the peritoneum. The bladder neck obviously is known as the internal smooth muscle sphincter, which is usually under adrenergic control, and there's the external rhabdosphincter, which is part of the pelvic floor musculature, usually to do with continence. And as far as innervation goes, obviously the autonomic nervous system, both cholinergic and adrenergic systems, have an interplay in both relaxation of the bladder as well as voiding. So bladder cancer may not be the commonest cancer. It is the 10th commonest in the world and 7th commonest in men, more common in men than women. and with an age peak incidence in the 60s to 80s. But it is a very expensive cancer in many ways for patients, for health systems. So even if the actual numbers may not be as many as other cancers, it does have a huge impact on patients and families and the system. Very common in the Western countries, industrialization may have a role to play, as well as social habits of cigarette smoking, as you can see in the data there. So risk factors, cigarette smoking, tobacco smoking is one of the most well-known, well-studied risk factor. Occupational exposures, thankfully, due to legislation, these are becoming less and less important, but every so often you will see people who might have had exposure to petrochemical industries, the dye industry, rubber, paint, etc. Even hairdressers who use hair dyes have been known to have been at risk. Chronic irritation of bladder, recurrent UTIs, spinal cord injury patients with long-term catheters, bladder stones, and also in the tropical countries, bilharziasis or schistosomiasis of the bladder, which causes a lot of chronic irritation over years, can tend to form bladder cancer, usually of the squamous cell carcinoma variety. We know that pelvic radiation for other cancers, such as prostate cancer or bowel cancer or gynae cancers, can sometimes carry a 2 to 5% risk of secondary bladder malignancies. So not all hematuria in people with previous radiotherapy is due to radiation cystitis. They need to be seen and referred and have scopes and further tests as indicated. A few drugs have weak but well-known associations with bladder cancer, cyclophosphamide, as well as pioglitazone, which is a diabetes medication. The referral criteria across both sides of the border are broadly similar, whether you look at NICE or the Scottish referral guidelines. So 2-week wait if they're age 45 and above with unexplained visible hematuria without a UTI, or if it persists or recurs after successful eradication of a UTI, or in patients over 60 if they have persistent non-visible hematuria with usually either dysuria or a raised white cell count. And you can still refer non-urgently patients over 60 with asymptomatic non-visible hematuria, but we know from studies that the odds of finding a significant bladder cancer are extremely low if they don't have any symptoms with persistent non-visible hematuria. Similar guidelines in the Scottish referral guidelines. The only addition is if there's incidental findings on imaging that we sometimes do get with other modalities. So the commonest presentation, as we know, is usually painless visible hematuria, what my mom had. Recurrent UTIs, dysuria, or just bothersome painful symptoms where you've tried anticholinergics and or antibiotics and things are not settling down, could be referred in for bladder cancer, especially if they're at risk, such as if they're smoking history or not. Rarely, patients may present with advanced disease, usually of either renal failure if there's obstruction of their ureters, or anemia, or weight loss, or features of metastatic disease, which is obviously very unfortunate if that happens, because we know that early diagnosis can lead to early treatment and hopefully good outcomes, like my mom. Incidentally, we do find bladder cancers, bladder tumors during prostate investigations or treatments. MRIs for prostate cancer can sometimes pick up a small incidental bladder lesion, or if someone attends for a prostate procedure, that can sometimes also pick up an incidental bladder tumor. So 2-week wait referral, 2-week referral from GPs to us when they come to a clinic, and ideally there should be a one-stop hematuria service. Not always possible, especially in very bigger centers, but at least if they have the upper tract imaging organized beforehand, because hematuria could involve other causes, including renal tumors, which are perhaps lesser, but nevertheless, I think getting an ultrasound scan and then bringing them in for a flexible cystoscopy, ideally on the same day, would be the ideal way of doing it. We've come up with special proformas with focused history, not just focusing on the symptoms, but also any significant past medical history and risk factors, together with a frailty score. We use the Rockwood frailty score on our CNS flexible cystoscopy one-stop shop, where it's very easy to assess a patient's performance status, because that will no doubt have an impact on if they need any further treatments or not. Urinalysis to rule out a UTI, routine bloods, Examination usually doesn't reveal much with bladder tumors, and it's really the mainstay of investigations are upper tract imaging and a flexible cystoscopy. There have been lots of biomarkers that have been tried, Eurovision, bladder check, an epi test and all those, and which at the moment are not yet used in diagnostics. They may have a role in follow-up and in trial settings. Unfortunately, there is no substitute, radiological substitute, which, at this day and age can replace a cystoscopy. Sometimes you can have flat lesions called carcinoma in situ, which will be missed on CT or MRI scans. However, MRI does have a role perhaps in better staging, but that's still being investigated with trials looking at what's called the VIRADS or vesicle imaging radiology and reporting systems. So sometimes when we send patients for scans, it's pretty obvious they have a bladder tumor. Like the first image on the left of your screen is an ultrasound scan showing quite a convincing bladder tumor. So, however, the differential diagnosis, not in this case, this is pretty clear, but if it's just a space-occupying lesion, it could be a clot. The next image on top with the dye, the contrast in the bladder is a CT scan, which shows a filling defect, again suggestive of a bladder tumor. And then the bottom picture there is an MRI scan, which shows quite a convincing bladder tumor there as well. So if we see these on imaging, they don't necessarily have to have a flexible cystoscopy unless there's doubt of the clot. And we would move straight on to the actual definitive management, which I'll come to in a second. But most patients will have a flexible cystoscopy, which is an office-based procedure. Literally takes a couple of minutes. And this is, again, a message for very anxious patients, in primary care. If you're counseling them that, this is what you may go for a one-stop flexible cystoscopy, it's easier than going to the dentist. And it's definitely a lot easier than having a smear test. And I think that bit of information certainly puts people's minds at ease. Otherwise they can be quite petrified at having a scope being put up their water pipe. At cystoscopy, obviously, whoever's doing the cystoscopy should document the numbers of lesions, the location, the appearance, that can help with the next steps. So after a positive initial test, whether it's a flexible cystoscopy or imaging, we counsel patients for a procedure called transurethral resection of bladder tumor, which is usually done under either a short general anesthetic or a spinal anesthetic. We provide our patients with information leaflets on TURBT, either from our national organization, BAUS, or from the charity Fight Bladder Cancer, which actually have amazing information leaflets available online as well. Clinical nurse specialist support is hugely valuable to patients because the cystoscopy service is often a very fast service. You're getting patients in and out with the current pressures that we're all facing. But when someone's got a bladder tumor, I think those patients need time. They need obviously a lot of support and making sure that the next steps are explained to them in a compassionate manner. Where indicated, if the cystoscopy reveals that it's multifocal or solid, then we would get full staging CTs, including chest, or if the upper tracts have not had a CT IVU, then we'd get those as well, and get them onto an urgent waiting list for the TURBT. Now, during COVID, we obviously learned how to prioritize based on patient and tumor factors. We came up with a table in Glasgow, which really helped, so that it meant that those at the highest risk tumors, so solid multifocal tumors, were prioritized, or maybe someone with a very small tumor, which may not necessarily grow, if they have to wait a bit longer. We also counsel patients about a single dose of mitomycin C, which is really a chemotherapy, but again, the word chemotherapy can send wrong messages to patients. They think they'll lose their hair, they think it's going to make them sick, but this is really an instillation through a catheter into the bladder. And the way I put it to them is, realistically, it's actually an antibiotic. It's a cousin of erythromycin, hence the same surname, but it kills any floating tumor cells. And it has been shown in several studies that a single dose of mitomycin after a TURBT significantly reduces recurrence in selected patients. So TURBT is using an endoscopic, a rigid cystoscope with a special instrument with a loop electrode that basically cuts away the tumor. And sometimes a lot of times we cut into the tumor, and therefore there'll be floating tumor cells, and that's where the role of mitomycin is very helpful. There are times when we cannot give mitomycin if it's a thin resection, or because there can be extravasation and painful symptoms. In such instances, we normally leave the irrigation to run for about 18 to 24 hours, and it has the same effect on reducing the risk of recurrence. Now, TURBT doesn't just eradicate small to intermediate bladder tumors. It also obviously gives us a diagnosis. It gives us a stage, a pathological stage. And like most hollow organs, the TNM staging or the tumor staging is depth of penetration from the mucosa to the muscularis and then outside. So without boring into details, if it's non-invasive, then it's TIS or CIS, carcinoma in situ, which is actually a high-grade disease because it can be multifocal. TA, which is non-invasive, and that's the best to have. And T1, which is where it's gone past the lamina propria into the submucosa. T1 and CIS are dangerous because they have a risk of progression, which is going into the muscle if not treated in time. And then obviously you have the muscle invasive, which are T2 and above. T3 is when it goes into fat, and T4 is when it's invading the pelvic sidewall structures. And that's again a similar sort of description that I've just discussed. So the histological subtypes, the commonest is urothelial carcinoma or transitional cell carcinoma. 90 to 95% of bladder tumors or bladder cancers are TCCs. You do have about 2 to about 10% or 5% being squamous cell carcinomas, especially with schistosomiasis or the recurrent UTIs or bladder irritations. And then rarely 1 to 2% are adenocarcinoma, which are usually in the dome and associated with urachal remnants. Patients with TCC, if they have a variant pathology, micropapillary, sarcomatoid, etc., there are lots of different pathologic descriptions. Those are usually high risk and need prompt treatment. Grading is obviously how angry the cells look under the microscope. That's how I describe grading to the patients. Staging is the extent of the cancer, on scans or clinical examination. Grading is under the microscope. The traditional 1973 system was quite easy, grade 1, 2, and 3. Papilloma is not cancer, it's benign. And then the 2004 system, which is what is being used more and more, is PUNLUMP, which stands for papillary urothelial neoplasm of low malignant potential or low-grade, high-grade. And these days, we really just see low-grade, high-grade, but most pathologists are using a combination of both systems. So they'll say low-grade G1, low-grade G2, or high-grade G2, high-grade G3. We then discuss all our cases in the MDT after they've had their staging scans, and the pathology has been reported. And broadly speaking, 75% of bladder cancers are non-muscle invasive bladder cancer, also previously known as superficial bladder cancer, but that word it needs to be sort of discouraged, that phrase. It's really non-muscle invasive bladder cancer is what most urologists use at the moment. And within this group of patients, you can have low risk, intermediate risk, high risk, and according to the European classification, also very high risk. NICE puts it really simply at low, intermediate, and high risk, and there are factors which determine who goes into what category, which I'll come to in a second. These are obviously non-metastatic cancers. Muscle invasive bladder cancer is obviously where it's gone into the muscle and beyond, but not metastatic. And then obviously metastatic bladder cancer, which generally carries a poor prognosis. Treatments for metastatic bladder cancer have improved after several decades. We've finally seen, research and new treatments in form of immunotherapy. The PD-L1 inhibitors do show some promise there. But otherwise, it has mostly been cisplatin-based chemotherapy and gemcitabine as well. Working with oncologists and the multidisciplinary team, clinical nurse specialists is absolutely key in treating bladder cancer. And also your radiation oncologists as well is absolutely key for especially the high grade or the muscle invasive bladder cancer and the metastatic ones. So as far as non-muscle invasive bladder cancer goes, and obviously this is the TCC, if it's a squame, treatments really are slightly different because squames don't respond to chemotherapy or radiotherapy or indeed any of the non-surgical treatments described here. So if it's low risk, which is a solitary less than 3 centimeter low grade non-invasive TA tumor, the risk of either recurrence or progression is generally very low. So all they need is just standard endoscopic follow-up. There's a slight variation in practice between NICE, which say if by 1 year there's no recurrence, they can be discharged from follow-up. In Scotland, we tend to follow, most centers in Scotland are following the EAU guidelines, the European guidelines, which take follow-up up to 5 years and then get discharged. I guess the the patient parameters in Scotland and the risk factors are perhaps slightly different compared to down south. So I think that's why we're a little twitched at discharging patients at 1 year. Intermediate risk is obviously anyone that falls between the low risk and the high risk category. And if someone has intermediate risk diagnosed at MDT, they go for a full course of intravesical mitomycin, which is weekly instillations once a week for 6 weeks. So they come in, get a catheter, mitomycin for a couple of hours. It's removed. They come back like that for 6 weeks, and then they go on to standard follow-up for 5 years. With the high risk, obviously the danger with high risk non-muscle invasive bladder cancer is progression. Progression is where the cancer grows from either Ta, T1 into actually T2. And once it hits the muscle, T2 disease is dangerous. So the treatment options are either intravesical BCG. Some of you may remember BCG is a vaccine for tuberculosis. The exact mode of action, how this cures bladder cancer, is not quite known. It has been used for several decades with protocols lasting up to 3 years. It is a live attenuated TB vaccine, bovine TB vaccine. It does elicit an immune reaction, and it is thought that that local immune reaction in the bladder is what kills the cancer. Results are not bad. About 60% of patients do respond. Some will not, they will fail, or they'll be refractory to BCG, in which case they may need further treatments in form of cystectomy. Alternatively, patients who are fit and well and who have quite a significant volume of high-risk non-muscle invasive cancer could be offered early primary cystectomy, which is a big operation, probably one of the biggest that we do, removing the whole bladder, for men, the prostate. For ladies, we can preserve the womb and the ovaries, but most times it all comes out, lymph nodes come out, and then we've got to replumb the waterworks either as a conduit, which is a bag for life, or a neobladder, which I'll talk about in a second. So it's obviously a big operation, but it does have a good outcomes. So muscle invasive bladder cancer, if there's no evidence of distant mets and patients are fit, then they go for radical cystectomy and urinary diversion, as we discussed. They may get neoadjuvant chemotherapy and sometimes adjuvant PD-L1 inhibitors. There is more evidence in favor of bladder preserving treatments. We don't really have good sort of evidence, but I think in selected patients it works well with TURBT chemotherapy and radiation. So that's a whistle-stop talk on bladder cancer management. We obviously have quite a lot to cover, but I just want to share with you this program called Getting Better Faster that I came up with as a cystectomist. So we've obviously heard of enhanced recovery after surgery, ERA, so enhanced recovery after cystectomies, and how is Getting Better Faster different from enhanced recovery? So the principles are exactly the same, but it's how we use a patient-centered approach in patient-friendly language, using patient empowerment and using an easy ABC guide. We actually started this program. I'd started it myself, but then I got others on board when I moved to Glasgow, and we've got audit data before we started this as well as after. Now, when you tell a patient with bladder cancer, whether it's my mother or any other patient, words like enhanced recovery or prehabilitation or rehab, and someone in Glasgow might actually think that you're talking of other aspects of prehab and rehab, to do with drugs and all that. So I think some of these medical words, medicalization of, our terminology, sometimes works against us. But the minute we say, look, we're going to talk about this program called Getting Better Faster, straight away they're on board, no enhanced recovery, no prehab, no rehab. So it's really using that patient-friendly language that has made a massive difference. So we've recorded all our data between 2015 and 2019, 2 years before, 2 years after we started the Getting Better Faster, and just under 200 patients, and most of them were open cystectomies. We excluded the robotics, and we looked at length of stay. So 71 patients before Getting Better Faster was introduced had a median length of stay of 15 days. We reduced that literally by 5 days just with getting this on board. And obviously, as you can see here, according to the type of surgery, so whether it was so after Getting Better Faster, it's pretty much at par with robotic surgery, which is the far right. And the two options are really the type of urinary diversion between ileal conduit and an orthotopic neobladder reconstruction. This is according to ASA and BMI. And we found that actually ASA3 had the biggest benefit in the getting better faster. Unfortunately, time won't allow me to go into details of this, but if any of you are interested, you can get in touch with me and we can, have a discussion. But it has been a very satisfying journey, just not just for myself, but for patients. You get to know them. It is a very team-based, patient-centered, holistic approach, which looks at, it puts their mind away from their cancer diagnosis and a big impending operation onto something that they feel they can control, which is their own well-being. We've written about this in Fight Bladder Cancer magazine, and I think this should be available either online, or if you ask Fight Bladder Cancer, they can provide you a copy of this. And in essence, it's really just before surgery having a decent chat with the patient and their family and empowering them. And when I start off, I normally start off with the ABC, and the first A is positive attitude. Once you've got them on board, then the rest of it's very easy. And I would normally tell patients that, look, even the most successful high endurance athletes don't just have physical coaches, they have mind coaches. And I normally appoint their partners or wives or husbands as their coaches. And we know for a fact that, if they've got it in their psyche that they want to do it, then the rest of the steps are very easy. Then a program of breathing exercises, controlling smoking or ceasing smoking, dietary buildup, exercise aiming for 10,000 steps a day, and obviously the Fight Bladder Cancer booklets. Post-op, obviously, it's a similar thing, but slight difference with, after surgery, with aspects of enhanced recovery that are well tested as well. So that's all I've got to say about bladder cancer. We're half an hour into our time, so I'll just move on to
Jamin, sorry, can I interrupt for a second? I just thought it would
Sure.
be nice to have a little break before we move on to the prostate
Sounds
cancer.
good.
Information to process. So,
Yeah.
I wanted to start. We've got a few questions in the chat. Hopefully, more will, people will add more to the chat. I'm really interested in this prehabilitation. One of the things we recognize doing a project in my PCN is those people who are waiting to have their hip operations and knee surgeries, and they decondition so much that when they're waiting and they actually go, they are two different people altogether, and their rehabilitation is so much more harder. And what we're struggling to find is the resource in the community to be able to do the prehabilitation. So was your effort more hospital based? Did patients come to you, or did you get that done in the community? How did you do it?
So that's a very good question. And so a lot of it's actually driven by the patients. And I think it's having that initial chat. And it was a constant battle initially with my management, because they would give me 15 minutes to see a patient and talk to them about cystectomy, about the bladder cancer diagnosis, the risks of cystectomy, and also rehab. And I've managed to get half an hour, but it's never half an hour. It's usually 45 minutes to 1 hour. And at the moment, we've got some funding, so we're making some doodle art videos, and basically making the chat that I have so that it's easily reproducible. Into videos that patients and families can have before they come and see me. And it's being beta tested with my own patients who've actually done getting better faster with me. And as one of my patients said to some other patients, and having patient buddies is very useful, is, you basically not trying to make them forget about their cancer, but focusing on their well-being, and empowering them. As far as the actual exercise programs go, anything they do over and above what they're not doing is a win. There are exercise programs available, and you've got to bear in mind whether it's a hip replacement patient who can't really mobilize, or if it's a 70-year-old, with multiple comorbidities, and bladder cancer. I walk my dog twice a day. I know how much it takes me to do 10,000 steps, and it's not easy, when you ask patients. So anything they're doing over and above their baseline is good, but it's got to be incremental. So I normally say, look, if you can start walking 15 minutes a day, slightly brisk, increase it to 30 minutes, make it 2 times 15 minutes, yeah, and then make it, so incrementally. Obviously, they don't have a lot of time for a cancer operation, usually about 3 to 4 weeks. If they're going for neoadjuvant chemotherapy, there's more time. And there will be some days when they'll feel rubbish after chemo. But again, using the A's of the ABCs and other aspects, breathing, so we're working on doodle art videos, and our aim is actually, and we're branding getting better faster, so it's not sort of plagiarized or misused, or it's not for any commercial reasons, but just to make sure that the original message and simplicity and the power of simple is huge is preserved in the way it's worked. So we are making exercise podcasts, relaxation podcasts, and I've actually timed how many steps it takes me to how many minutes with different tracks for 1,000 steps, and and just keeping on. And so I've actually got some tracks. So we've got a family-run podcast company that we're going to make, and these are walking steps, and then there'll be a slow pace, a fast pace, so people can choose what they want. Um, we have Maggie's centers in Scotland. I don't know if you have them down south, but they're great, and they have prehab sessions for all cancers. Now, I know a lot of focus for prehab and enhanced recovery is for cancers, but you're right. I think getting better faster should be ubiquitous. It should be universal. It should be for anyone. My dad had a nasty gallbladder. He just turned 88 yesterday. He had a nasty gallbladder perforation, and that was initially managed conservatively, and then he had to go for major surgery just 4 years back during COVID when he was 84. And I spoke to him about getting better faster, and he started doing his laps around the garden in his own time and pace, and that made a huge difference to his recovery. So I think the power of simple is often underrated.
I can hear the passion as you're describing this, and I'm really hoping that people who are here, G is here, and the personalized care workforce, there's so much potential for MDT, taking this away from the clinicians and other healthcare professionals doing this prehab. So, hopefully you'll have more invites to people inviting you to come and talk about this. There's just one another question, which essentially says, intravesical BCG, is this the same as the vaccines we use for children?
That's correct, yeah. So we use BCG for people from the tropical countries. I've had my BCG scar. I'm from Kenya originally. So yes, it is the same. And there was a shortage globally last few years back because it's a live attenuated vaccine, and we had to, change the way we were doing things temporarily. But thankfully, that's now not a problem anymore. But yes, that's the same one.
Thank you. So maybe we carry on with the prostate cancer talk and come back to the questions. Thank you.
Thank you very much. So again, a big topic, very close to my heart. I don't know if Bunmi is back. I'm not sure if I'm sharing it. Screen. So we'll skip through some of these. I mean, I guess everyone knows what the prostate is. It's a male accessory gland. It has the zonal anatomy. The peripheral zone, which is what's normally felt on DRE, and I know Prostate Cancer UK said DRE is not mandatory, is where the bulk of prostate cancers used to tend to arise, but sometimes they can occur in the anterior parts as well. Again, just a bit of basic science. The fibromuscular stroma, which is what contributes to BPH, and that's where tamsulosin tends to work. It relaxes the smooth muscle, versus the glandular epithelium, which is where the finasteride works, but also where the cancer arises. Obviously, the functions of prostate are, it produces prostatic fluid, which nourishes sperm, contributes to semen. It also produces PSA, which is a serine protease enzyme that liquefies semen to allow the sperm to be able to swim freely. We've seen these slides, all over, and I'm really privileged and honored to be a prostate cancer UK clinical champion, like my friend Bunmi, where we met. Prostate cancer is the most common cancer in men in the UK. 1 in 8 men for all comers, and 1 in 4 men of Afro-Caribbean Black men of Afro-Caribbean origin, or if there's a family history. And again, really excited to see the news recently of the Transform trial, which will inform us of the best way to screen. And there's a bit on screening that we'll discuss shortly. Sorry, I'm just going to. So we know that, yeah, it is obviously very common in Western and Northern Europe, and also highest incidence in the Australasian countries and North America. We think Africa it's a big problem, but the true rates are not known due to underdiagnosis and lack of PSA testing. We do know that it behaves very differently in African populations with, much worse mortality. So that's the global incidence of prostate cancer. You can see the dark blue is where it tends to occur more commonly. Asian countries seem to be spared, and there may be a genetic influence there. And you can see the mortality again. You can see the dark red, obviously centered around Africa, and obviously Turkey seems quite dark, Brazil and Caribbean as well, and then Northern and Western Europe as well. So risk factors, obviously age, increasing age is a risk factor, ethnicity, genetics. If there's a family history of prostate, breast, or ovarian cancer, the true hereditary risk is really 9%, but BRCA2 gene is obviously a risk factor. Diet, there are several associations, all of which are weak. People thought that testosterone therapy was an independent risk factor, but it's not. If anything, hypogonadism is a risk factor. And recently, Toronto, where I did my fellowship, male pattern balding was found to be an independent risk factor or an association of not just having prostate cancer, but also high-grade prostate cancer. So again, age, as we said, 60s, 70s, mid 70s, and then less testing in the over 80s. That's over time from the 1970s to 2011. And there was that Matterhorn-like peak in the 1990s. That was because of the introduction of the PSA testing. You'd think that introducing the PSA test would reduce the mortality, and it didn't quite reduce it that much, but you can see almost a trend from mid 90s downwards of a reduction there. So presentation, most prostate cancer is asymptomatic, and the only thing that brings them to us is a high PSA test. We know PSA is not a perfect test. It can go for various reasons, and that we will feature in my filters and cascades talk. Abnormal DRE, we do sometimes find patients being referred with abnormal DRE. If the PSA is raised, if it's greater than 3, then obviously that's slightly concerning. The higher it is, the PSA, then obviously that's more concerning. They may present with urinary symptoms, which may be coincidental due to concomitant BPH. Hematuria is a rare symptom, but it can happen. Blood in semen and ED, new onset ED, are also symptoms of prostate cancer. Obviously, advanced prostate cancer, which we still unfortunately see quite a lot, especially in Scotland and Northern England, presents with, constitutional symptoms, weight loss, bone pain, anemia, very high PSA, triple digits or higher. Occasionally, we do see malignant spinal cord compression, which is an emergency admission, or renal failure with ureteric obstruction. And interestingly, I saw a man not too long ago with a PSA of, I think, 3,000, no symptoms at all. And last week, I saw another man, or 2 weeks back. He wanted to donate his kidney to his daughter. Again, fit and well man in his late 50s, no symptoms at all. The transplant coordinator ran a battery of tests. PSA came back at 800. Bone scan full of mets. So that's unfortunate, and obviously that's that genetics. So referral guidelines, I'm not going to bore you with them because you know them. There is a move at the moment to try and use a solitary number. So the GIRFT document published just last week or 2 weeks back, GIRFT getting it right first time, Carolyn Moore and team are coming up with a suggestion that PSA in men over 50, if it's 3 or higher, they should be sent in for referral. Obviously, the NICE and the Scottish referral guidelines at the moment are using age-specific range, as a referral guidelines. Obviously, men over the age of 80, realistic medicine, if the PSA is not greater than 20, unless they're very fit in their early 80s and they might have, high-grade cancer needing treatment, I think it's becoming less of an issue to over-investigate them. So that's just a comparison side by side of the Scottish and the NICE guidelines, and you can have a look at my slides later on the video recording. Now, this is where I regularly, so I run the high PSA clinic in Glasgow, and this led to my project, the Filters and Cascades, and I'd regularly get USOC, stands for Urgent Suspicion of Cancer, USOC referrals of patients with high PSA. And in the blurb of the referral from the GP, it says, I had an E. coli UTI, PSA was 30, I've checked it again, it's now 18, it's still high C. It takes up to 6 weeks for the prostate inflammation from a UTI to come down to a level. So, don't test 5 days after antibiotics or, after completion of antibiotics. Don't test even 2 weeks after. Give it at least 6 weeks. And if it's coming down, hold fire and recheck again at 3 months. And if it's normalized by then, you don't need to send them for prostate cancer suspected referral, you can send them for the UTI, and we can obviously investigate them, because male UTIs are, they shouldn't really happen. To screen or not, I mean, we could spend all day talking about this and still not agree, but let's watch what the space says with Transform. Traditionally, the European screening studies and the American studies, PLCO, did show actually that, so PLCO was a flawed trial because it was contaminated. They didn't really compare a screened versus non-screened arm. They compared a screened with versus a less screened arm. There's contamination there. So I think results of that trial have now kind of been, not given that much of importance. And the American recommendation of do not screen has changed from, I think, a D to I think C or something, whatever. European trials have shown that actually, numbers needed to screen, numbers needed to treat continues to reduce as the years go on, similar to breast cancer screening trials. On one hand, we know early detection can lead to cure. On the other hand, obviously, there's a risk of over-detection, over-treatment, and this is where I think hopefully Transform will inform us of individualized risk strategy. The harms of detection and over-treatment have been reduced significantly, and yeah, as I said, it would be helpful to see what this trial tells us. That's the Wilson-Jungner criteria for screening, 10 things that need to be met before any program can be offered screening. This is a really helpful piece of information, from Government UK on advice for men, and this is both for GPs and for patients. I'd strongly recommend that it's used more and more. And that's just, again, a one-page document about, the PSA as well as the merits and demerits of it. These are the European guidelines. Again, it says offer early PSA testing to well-informed men at elevated risk of having prostate cancer. So men from the age of 50, unless they have a family history of prostate cancer or of African origin, when in that case, bring it down to 45. And obviously men carrying the BRCA2 mutation from the age of 40. So Transform's already being launched. Hopefully by next year, we will be recruiting. So when patients are referred to us to clinic, I normally get a urinalysis on arrival and a post-void scan, because sometimes they could be in retention, chronic retention, and the PSA may be up as a result of that. We look at their comorbidities, family history, MRI safety, etc., and examine them, and then obviously check their kidney function. If required, we may repeat a PSA if there's any doubt of a UTI. Imaging normally depends on the level of PSA and other conditions. So most times we go for an MRI scan for most of our patients. In Glasgow, we tend to use mostly biparametric MRI, which I believe is probably going to be the main type of MRI scan for the Transform trial, I believe, because it will be easier. It's a faster scan as well, and you don't need contrast. And actually, studies have shown whether you go for biparametric or multiparametric. Piru, Cassie, Viswanathan, I think he presented recently his data, which at the EAU meeting, which shows no difference whether you give people contrast or not, so long as you have a good radiologist. Sorry, Bunmi, if you don't mind. Thanks. And then obviously, if PSAs are very high, we might get a whole body bone scan as well, and maybe CTs if required. And then biopsies, whether we go for transperineal or transrectal, there's a move globally to move towards transperineal, but obviously it does require the relevant setup and expertise. So that's just a picture of the MRI scan showing the tumor there. You may have come across the PIRADS system, prostate imaging reporting and data systems. Again, patients might Google and say, oh gosh, PIRADS 5, I've got cancer. Regularly, we see PIRADS 5. If people have had a UTI or granulomatous prostatitis, we'll show like a T3 PIRADS 5, and it comes back as just inflammation. So the way I talk to patients is, look, a shadow is a shadow, just the same as a high PSA is a high PSA. Neither of these are diagnostic until we've got proof in form of a biopsy. So you might have, a PIRADS 5 lesion. Yes, it may be concerning, but that's why we're going to do biopsies, and there is a small chance that it may not be cancer. Equally, a normal MRI scan, according to the PROMISE trial, up to 6% of men can get 6 to 15% with a low PIRADS score can have clinically significant prostate cancer, which can be missed on a normal MRI. And NICE actually puts this at a higher figure. So biopsies, obviously, I think is important. Counseling, the risk versus benefit, the approach, and as I say, targeted biopsies is the way to go. as opposed to the standard trust sampling biopsies that we used to do. These are some of the risks associated with biopsies, both in the NICE and the BAUS documents. Bleeding is very, very common, and patients may present to you, but I think, again, managing expectations and informing patients adequately at the start of the journey by us when we're booking them for biopsies is vital, that everybody passes blood either through the stool, in the urine, or in their semen, and this can last for weeks. Unless you're having a temperature, unless you're having pain, unless you're not able to pee, unless you feel really unwell, you don't need to worry, it will stop. Sepsis rates are low, obviously much less with transperineal. Retention, thankfully, is a rare event, and then some people can get a bit of bruising. My general advice is also do not travel, overseas for up to 4 weeks after biopsy, especially if it's an area where there may not be good medical cover, or make sure you have good insurance. Gleason was an American pathologist, Donald Gleason, in the 1960s. I'm sure you come across Gleason grade. So he looked at thousands of biopsies and came up with this very simple, again, power of simple, descriptive pattern of Gleason scoring, and still, very used 6 decades down the line. That's a diagram I drew in theater to teach the juniors, using smiley faces. Again, and I use that all the time for my patients. It puts a face to a cancer, and when you're discussing a low risk cancer with smiley faces, it's a 3 + 3 = 6 or a 3 + 4 = 7. I think it actually makes it more understandable to patients rather than throwing just numbers and equations and scores and all that. So this explains to them, actually, my cancer is not so bad. I could watch this. And again, it's about how you explain it and how it gets, into their mind for them to accept treatments like surveillance. TNM staging, I won't bore you with that. So risk factors or risk categories. So this is for non-metastatic prostate cancer. Traditionally, we used to say low risk, intermediate risk, high risk based on PSA, the Gleason score, and the T stage. And again, you can see that there is survival analysis which shows, low risk doesn't really have bad outcomes no matter what you do. And the Cambridge Prognostic Group classification, which is a new thing, which I think is really helpful because from 3, we've got 5 groups, and it again rationalizes the whole pathway. Obviously, patients with CPG 4 and 5 have bad disease and they definitely need treatment. CPG 3 do need treatment, but sometimes some of them may not necessarily want treatment, so there's a bit of breathing space. CPG 1 definitely need active surveillance, not need, but that's the recommended treatment. And CPG 2, again, can have active surveillance, or for some CPG 2s and most CPG 3s, we're looking at probable radical treatments as well. So again, that's just the grade grouping and the CPGs as well. So we discuss our cases at the NDT. This assign the TNM group, the CPG group, the grade group. Now in Glasgow, if the CPG is 2, but if they have any cribriform pattern, or if they have a pattern 4 greater than 10%, we normally recommend treatment. In England, I think CPG 2s more or less get a discussion of surveillance together with all the other treatment options. So we would offer surveillance to men with a CPG 2 Gleason 7 prostate cancer if there's no cribriform, or if the pattern 4 is less than 10%, and that's based on European guidelines. It's got nothing to do with Brexit, I promise you. Metastatic disease obviously is a different beast, and getting these people started on androgen deprivation therapy, hormone therapy early is key, and then obviously staging them, grading them, and then offering them other systemic treatments is also very vital. And this is where I think holistic discussion on bone health, mental health, all that is absolutely vital. And again, my beeline for patients with metastatic prostate cancer is it's not an imminent death sentence. There are treatments which will control your cancer, and you could get years out of your treatments. And I think that's very important when someone's told they've got cancer that's spread everywhere else, because straight away that they think they're going to die. So again, I'm just going to skip through this because of time. Surveillance is a great treatment option. I've had the pleasure of working with Laurie Klotz in Canada during my fellowship. We wrote a paper together on overtreatment in cancer, and it's really a balance of overtreatment, quality of life harm versus all the benefits between treatment and surveillance. And the key with surveillance is it's got to be active. Sometimes in the NHS, patients slip through the net because of admin errors or whatever else. Clinics get cancelled, they move to a year later, and that's where patient empowerment, you have every right to phone your consultant if your clinic's been cancelled, so that you're seen in a timely manner, so that you don't slip the surveillance net. Watchful waiting, obviously, is when patients are unwell, that treatment's not going to make any difference to their longevity. I'm sorry, I'm just going to whiz through these slides. Surveillance is a topic on its own. So really, holistic assessment for expected life expectancy. You would offer surveillance if men have at least 10 years of an expected life expectancy. And there are certain tests, including gait speed test, which I find very useful when I see patients face to face in my clinic, or also the Charlson Comorbidity Index. And after certain years, if men are starting to get into their mid-80s, then surveillance can fade into watchful waiting. Obviously, we know surgery and radiotherapy work just as well in treating prostate cancer where it's needed, especially the high-grade tumors, the CPG3s and upwards. Active monitoring, again, Freddie Hamdi, great guy. He was my supervisor, my trainer in Oxford. And, again, a very helpful trial in discussing treatment options with patients, which really helps to discuss that. If it's low risk, again, you don't need treatment. We can see we've got evidence to show that from the PROTECT trial. So I do robotic prostatectomies every Friday. It's a game changer in recovery, in blood loss, and also in outcomes. Radiotherapy, I think they're again moved to try and reduce the dosing, but increase the dosing, but reduce the duration, and focusing the treatments so that there's less bystander injury. Recurrence after radical treatments obviously is another topic of its own. We are using more and more of the PSMA PET CT scans currently just for biochemical relapse. I think it should be a good staging scan in patients where we are able to get it well resourced. I think that's already happening down south. So as we've said, metastatic prostate cancer obviously is very common in many parts of the country, and reversing the trend is absolutely key. Freddie Hamdi feels that actually it's a different set of patients who present de novo with metastatic disease, like the patient wanted to transplant donate his kidney, and trying to find out their risk much earlier on before they become metastatic. I think that's the holy grail. Whether or not screening will achieve that, it remains to be seen. Certainly from Freddie Hamdi's study of 15 years, there was no massive difference. They did have a screening, the CAP trial within the PROTECT, and that didn't really show any benefit. So it's interesting to see what the Transform will show us, because obviously PROTECT was before MRIs came into being. So filters and cascades, very quickly, over 2 minutes, is an efficient diagnostic and treatment pathway. It was my project for the Prostate Cancer UK Clinical Champions. The 5 Ps, personalized pathways, which are patient-centered, prioritizing, preserving resource, preventing missed delayed diagnosis, and promoting best practice. And these are just results from a pilot we did last year, which is the initial hospital phase. I'm delighted that our GPs have come on board, and we're actually changing the Sky Gateway referral so that a lot of the filters are built into the initial referral. So this was the traditional pathway. GPs would refer patients, the on-call consultant vets to a high PSA clinic where we'd see the patient, traditional pathway, assess them, blah, 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 and request the relevant scan. The scan gets done, and then afterwards the clinician actions on it. Now, if I'm on leave when the scan's been reported, it might be another 2 weeks before I act on that report. With filters and cascades, we're going straight to test. This is already happening in some centers across the country, Royal Marsden and I believe UCL. But we've kind of taken it a step further and prioritized the pathway based on patient parameters. We go straight to test. Once it's done, they come to a clinic, and that time frame hasn't changed, but they're coming with the benefit of a test, and straight away we get them onto biopsies. So these are the 3 cascades and 3 filters. If the PSA is greater than 100, we do not do a MRI scan. They go straight for a bone scan, CT scan. They come to a 2-week clinic where we start them on treatment if we think it's metastatic, and arrange biopsies. Cascade 2, 20 to 100, no UTI. They get an MRI and bone scan if they're under 80. If they're over 80, they get just a bone scan and clinic. And Cascade 3, which is the bulk of our patients, so long as there's no UTI, they go straight for an MRI. The first filter is obviously UTIs. Do not scan them, do not bring them to a clinic, treat them, see them. So we're not discharging them, we're bringing them to a 3-month PACS clinic. Filter 2, over 80. If the PS is less than 20, it's a case-by-case assessment, fairly hands-off approach unless someone's really fit. And then filter 3, which we see quite frequently, if the PS is normal and it's an abnormal DRE, we will see them face-to-face, but at a slightly deferred appointment. So we have piloted our results, and you can see they speak for themselves. We brought down GP referral to first appointment from 40 to 2 days, from GP referral to MRI scan from 52 to 13 days, and GP referral to biopsy decision from 72 to 27 days. For the metastatic patients, it's even much, much better. So again, similar referral to first appointment, bone scan within 2 weeks. Treatments started median 32 days compared to 90 days before. So staggering results. These are patients who have the worst form of prostate cancer. They need to be seen fastest. If there are only 10 slots, why should 40 referrals with UTIs, with a low PSA, Gleason 6 prostate cancer, 80-year-old with a lowish PSA of maybe 7, have to compete with the man with a PSA of 800? That's how filters and cascades came about. It prioritizes, it personalizes pathways. Final slide. So before filters and cascades, we compared this with a historic audit set from last year before filters and cascades came about. 84% of patients with metastatic prostate cancer missed the 62-day target. After filters and cascades, 88% met the target. I don't like the word targets. I think that's a political managerial admin thing. For me, quality and ensuring that patients get the best standard of care, based on their own individual parameters, personalized to their circumstance is what's important. And if it meets the targets, that's a bonus. The one patient who missed the target in this group had a small spot on his cheek, on his jawbone, which on review turned out to be a MET. So that's why, rightfully he wasn't started on treatment, because it needed clarity. And with that, I'd like to end my second whistle stop tour on prostate cancer. Thank you.
Thank you very much. We'll move on with oh, Sangeeta, can you...
Sorry, apologies.
Sorry,
Yes,
it's okay.
yeah.
All right. Yeah. There you go, G.
All right, thanks. Thank you, Chairman. That was amazing. Love the last picture. Brilliant scenery. I'm G. I'm the Senior Health and Wellbeing Coach, also a registered naturopath and yoga specialist with some experience in critical care. I'm going to be just sharing a few slides on how personalised care roles in primary care can support these patients. Next slide, please. So we often find that patients who are referred to the personalised care team, we receive them in a state of distress, fatigue, fear, anxiety. And really, we work as a team to find out what really matters to them. What are the social factors that are contributing to their state of well-being, their lifestyle, and also help them navigate their care plans. So we're really helping them bridge a more healthier lifestyle choices, and we work together with the community. So it's really a holistic support package. Next slide, please. What does this look like? How do we help them restore their well-being? From a health and well-being point of view, it's more of a coaching flow. So 60 minutes per session and across 6 sessions. So we have really got time to explore person-centered care. We help them set an agenda, gain a bit of clarity around their current situation, and we listen. It's active listening to elicit the patient's story. Everyone's got a story, and really 80% of their stress, of their fear, is just having someone to talk to explore what's going on behind the scenes. We do a bit of goal setting and problem solving. So it's really encouraging patients to connect with what's important to them, and also to connect them to local support groups. Jamin mentioned that some patients slip through the net, and I've got plenty of examples of actually seeing patients like that. It's really also putting a realistic time frame on their recovery and their restoration of well-being. So it's a very slow and steady pace. Next slide, please. And how are we making a difference? Here are some of the feedback that we've received from patients. Things like, I've been looking for this kind of service for a long time. After the first health coaching session, I felt a sense of calmness, which resolved anxiety. We're really helping patients to take more control and be able to make informed decisions about their care. It's an integration of services across clinical and non-clinical. It really strengthens relationships between the patients, healthcare providers, and community, and of course, the outcomes of better adherence to the medical advice and lifestyle changes. That's it. Thank you.
Thank you so much. Thank you, G. Oh, thank you, everybody, for participating and being here. Thank you so much, Jamin, for the wonderful presentation. And thank you as well, Sangeeta, for navigating the questions. And we have also Dr. Bumi here as well. So I don't know if you want to say anything, Bumi. Whilst I put in the chat, by the way, everyone, I'm going to put in the feedback survey, multiple choice, 10 seconds. Just say what you think. The only thing you'll have to write down is your name. So I will do it right now.
Before hi, Bumi, I'm really sorry. There wasn't enough time to allow Q&A.
Oh, yes.
I'm sure people would have had so many questions to ask. So maybe, Bumi, is it possible that people send the questions to Yasmina, and then maybe we could get some answers from the consultant if possible? I'll leave it to you anyway. Thank you. It's lovely to see you.
No, most definitely. And I really do want to apologize for turning up later. It was an emergency I had to deal with. I just want to say